So let's move on to the next presentation, I think.
Yeah, and the next presentation deals with the PET. We are all quite familiar with performing PET scans in patients with suspicion of GCA, but now Professor Slart from Groningen, the Netherlands, will extend on the rule of PET-CT in the context of large vessel vasculitis, especially for the diagnosis of disease, but also for monitoring of disease. Our warmest welcome to Rahmen.
Hello, Christian. Good afternoon. Yes, I will talk about PET-CT imaging in large vessel vasculitis and the question of why will come at the end. And yeah, when can we image vasculitis with the PET-CT imaging? We are a little bit confronted with the resolution of the system. So large vessel and medium-sized vessels can be imaged on PET imaging because the maximum resolution of the highest and newest systems is 2 millimeters to max 8 millimeters these days. So only the larger and middle-large vascular structures can be imaged. So before we start, we inject fluorodeoxyglucose, that's the FDG variant. We need some information because particularly drugs can also reduce the signal on the PET scan, like steroids, antibiotics, but also interventions can result in some additional hotspots on the scan. This is an example of normal distribution, normal uptake in the brain, vocal cords, heart, myocardium, liver, excretion by the urinary tract. And this image is performed 60 minutes after injection. I'll directly go to the first patient, a 70-year-old lady, headache, hair pain, weight loss, increased inflammatory parameters. Ultrasound biopsy was negative, and the question was, our department, vasculitis or lymphoma. An FT PET scan was performed. This is the PET scan. You see a high uptake in the different arterial structures like carotid arteries, the subclavian arteries, a little bit in the axillary arteries, aorta, iliacal arteries, and also uptake in the femoral arteries. And actually, this is a typical example of a giant cell arteritis on PET imaging. Also, different examples. The first one is a patient with GCA and also in combination with polymyalgia rheumatica. You see uptake at the shoulder region, at the synovia, but also at the hip area. Also, spinal cord is active. If you look here at the cervical level, but also at the lumbar level. So this is actually a mixed disease. If you go to the other one, it's a typical example of polyarthritis nodosa. The center part is negative, no uptake in the aorta, but if you look at the subclavia and the carotid and also the axillary branch, they are active, as well as the femoral part, including the branches here of the femoral arteries. They're also active. It's a more pattern that fits to polyarthritis nodosa. So if you look at a disease like GCA cranial, large vessel, and PMR, is actually in a disease continuum. It can be solely GCA on PET imaging, or it can be solely PMR activity on PET imaging. There are several examples. There are actually a mix of both diseases. This is another example of some patients. The intense uptake in the aorta region. And this is a patient after the prosthesis, vascular prosthesis implantation. But later on, it seems that the cause is also by the aortitis. This patient was treated with steroids, high dose, and the activity completely disappeared. So what is the performance of PET in GCA? It's from 80 to 90%. This is the way of scoring. We score from a grade 0 to 3. We compare it against the liver. You can add all the care per segment until the vessel score. Grade 2 and 3 is actually specific to vasculitis. It's a lower, mainly is due to atherosclerotic activity. But be aware of steroid treatment. It can reduce the signal. It can also, in grade 1, can also be in vasculitis activity. Look at distribution pattern, diffuse vasculitis, and focal atherosclerosis. And also combine with low-dose T for calcification to confirm atherosclerosis. You can quantify it also by standardized uptake value. And again, you can quantify it against the liver or a blood pool, and then you get the so-called ratio. Example of 3 different patients with a mild disease of GCA, a moderate disease of GCA, and an extensive disease of GCA. It's visually and also quantifiably expressed. The same for PMR quantification, mild, moderate, and severe. The knees, the shoulders, and also here the hip region is very prominent here. But be aware of steroids, prednisone. The study also proved that till 3 days, signal still active, high active on PET imaging. But if you treat the patient longer than 3 days, the signal will reduce on the PET scan. And all the procedures described here in this procedural paper, combination of imagers in combination with rheumatologists to increase your performance to the highest level with PET imaging. Pitfalls, many pitfalls. Also, I mentioned already the drugs, steroids, can also reduce the signal. Atherosclerosis can give some artifacts. This is an example of atherosclerosis, a patient with some dilated ascending aorta, some faint uptake, heterogeneous in this area. And actually, this is a typical example of an atherosclerosis activity. We can also combine it with CT, this is diagnostic CT. We combine molecular imaging in combination with morphology, so they can add to each other. You can improve also your image by delayed imaging. 2 hours is evaluated by Grayson. He saw a high signal in a true positive patient, and particularly in relapsing patient, it was of value. And these days, the cameras become better and better. The quality is high, the resolution is better. So also, this is possible to score the temporal artery, maxillary artery, the vertebral arteries of the cranial area. It's also possible with the high sensitivity cameras these days. And this is an example of a digital PET, the vision digital PET here. And the maxillary artery is visible here. The same patient is also scanned with a conventional MCT, conventional PET-CT system. It's hardly to see there's some activity here. So all the new camera systems improve the resolution of the smaller vascular structures. Monitoring, some important studies also published in the past. This review evaluated 8 high quality studies, and to evaluate the effect of therapy during follow-up PET scanning resulted in some good moderate sensitivity and specificity. But the study were very heterogeneous, and particularly variation in clinical aspects in the imaging procedures that contribute to the heterogeneity. Last case, man with abdominal pain, cellular adenitis, increased CRP, underwent a PET scan, abnormalities. Now, if you look well, you can see already abnormality here. Give your hand with some more detail, different views. High activity around and also in the abdominal aorta, also in the coronal view here. There's some mass visible on the CT. There's some patient aortitis, but also an IgG4 mediated disease, and also active retroperitoneal fibrosis visible here. This patient was treated, and 1 year later the activity was gone. Also, the mass was more or less gone here on this PET-CT image. So, coming to the key messages, criteria for interpretation. Look at the uptake against the liver, as well as vascular as joint structures. Be aware of steroids and atherosclerosis. Look at the pattern. Technical benefits, digital PETs, cranial evaluation is possible now, and maybe it can be helpful to inconclusive pathology or ultrasound. New cameras have faster and lower radiation dose. We have a total body PET, so we image all the affected artery structures. We can also look at disease spectrum of PMR and vasculitis, and we can also come up with an alternative diagnosis in patients with fever of unknown origin. We can quantify it also. It will be very handy for therapy monitoring in combination with clinical and biomedical results. It's not always easy, scans. You all have to discuss it again. It's very important in your expert team in your own institute. Okay, this was my last slide. Thank you very much.
Many thanks, Rima, for your clear-cut presentations. Now, we really want to remind our participants to keep in touch with us, and we really ask you for your interaction. And hopefully there will be some questions.
Yes, people, please ask. So we were talking about PET with a P and not about the bed. So please stay awake and ask questions. Be interactive. So Wolfgang has a question, but maybe I can start before with one. So I wanted to point to your message that to your case that was borderline at 1 hour and clear positive at 2 hours. I read a paper where they made a comparison, 1 hour acquisition time, so 1 hour after the injection of the radionuclide and 2 hours, and the sensitivity was much higher. So my question to you is, should it not become a standard to do the acquisition for large vessel vasculitis always at least 2 hours after the injection of the radionuclide?
Yes and no. I agree with you to do it after 2 hours. It will improve the quality. It's not only the higher uptick in the vascular wall, but it's also better clearance of blood pool activity. So that makes the targeted background better. That's actually the trick behind delayed imaging. It will improve, but you have to look at the practical issues. Patient has to wait longer. Instead of 1 hour, they have to wait for 2 hours in the waiting room. And other issue, if you're working these days, we have now 2 digital camera systems in our department. The quality is so much higher these days and also so much more sensitive. I think if you compare it again, then I think the digital camera system already works out. But 2 hours, yeah, in the conventional imaging system, it will be very helpful, I think so. And particularly when you suspect a patient of relapsing.
Okay, Wolfgang?
Yeah, hello. I see a problem, at least in Berlin. We get quite a lot of reports for PETs, and the physicians only report on the PET and nothing on the CT, but it's PET CT. So I often see, okay, there is enhancement, but I would like to have information on the wall thickness, because I sometimes have difficulties. We look with the ultrasound and it's completely normal with the ultrasound, and there is no description on the morphology. That's my first question. And if you do CT, have you ever seen any pathology by CT in the PET CT on the temple or the small arteries? Because we have no data on that. But my main question is actually, I feel that some nuclear medicine physicians, at least in our area, do the PET CT, but don't say anything about CT. And I feel this is a little bit crazy.
Yeah, to be short on that, it depends a little bit on the institute. In your institute, apparently you perform a standard diagnostic CT with a PET. We don't. We do only low dose CT in combination with PET. And to come back to the low dose CT, we always look at low dose CT also for incidental finding, lung nodules, whatever. You've always looked at the low dose CT at least. So we don't do it by ourselves directly. But the combination is very important, I think, particularly in morphology. And particularly when you do a follow-up of the patient with a diagnostic CT and a PET in this case then, because you also have to look at the aneurysm formation, the kind of stuff. You will not be aware so quickly on a PET scan. So you really need then also a diagnostic CT. Do we see some aneurysm formation or stenosis or something, also an irreversible stenosis? What do you see also there on the CT? I think it's very important, but it's not our general practice here in Groningen.
I think that Thorsten wanted also to comment.
Yes, maybe I can allude on this as well. And we have been talking about team efforts, and PET CT is a combination of nuclear medicine and radiology. And I think if it's read by the 2 disciplines, then Wolfgang, the CT part would also be having a higher impact. And that's what we perform in our institutions, to combine nuclear medicine with radiology experience.
I could confirm we do the same, but we don't do so often CT in GCA. We do co-reading. Yeah, exactly. And we have a crossover in the Netherlands. You can also do by yourself these days. Yeah.
It's really great. So I have another question concerning PET in the phase of remission or in the long-term monitoring. So you know that we have sometimes these patients which are in complete remission clinically and have no CRP, and somehow has the idea to make a follow-up PET scan, and then the patient still is positive. So how do we interpret that?
Yeah, that's also that's a difficult question. You saw it also to the review we wrote about that, because we also had the same question to that. How reliable is PET in follow-up? First of all, again, I think the delayed imaging could be helpful for relapsing of ongoing disease or smoldering disease in the vascular wall. That will maybe improve it. You really have to compare it also with other findings on the PET, particularly on the low dose T. How extensive is the atherosclerosis, this area? There's also interferon signal. And all that together, you have to find the most optimal performance on your PET scoring in the end in this way. But it's not always easy. yeah, another step is, but it's a step really further, look for more specific tracers. To be honest, FDG is not a very specific tracer. It's an inflammatory tracer, but also for tumors. You can use it there for everywhere. So specific trace would be helpful, but there's another step, I think so.
I think what you said also in your last statement, that for tumors, I think that's really another very important indication for PET. So, you know, when you have these patients with fever of unknown origin, and you may suspect they have also some myalgia, and you may suspect vasculitis. And there was a paper, I think it was from Peter Grayson's group, and they identified that 20% of the people in such a cohort had some incidental tumors or infections that were clinically relevant. So I think that's another not to underestimate value, so a value that should not be underestimated of PET. Would you agree?
Yeah, I fully agree. We have the same experience because there's actually clinical reality. Patients come in with fever unknown origin. Everything is negative. Microculture is negative. They cannot find anything. Conventional imaging is negative. And then they come off for the PET. What is the final? In the case around 20 to 25%, we will find alternative diagnosis: a tumor, lymphoma, sarcoidosis, infection, endocarditis, also sometimes infected implanted materials. Also, there's also a key player in this kind of patients. Yeah, that's very important. And many times we can find something. Infected cysts of kidney sometimes. Yeah.
There are two more questions in the chat. The first one is whether all patients with GCA should get a PET investigation. And the second one is regarding the follow-up of GCA patients, whether all patients should get a PET investigation, a PET examination during their follow-up. What is the opinion of the experts, please?
Maybe I can better not answer it.
I think you are the person who is asked to answer this question.
Okay, I can answer. Now it's difficult to say because it depends also on the applicants. Is it really needed? Not every patient will get an FDG PET scan. I think when it's an unclear case, they will come over here for the PET scan. Now, in our academic center, in general, we will scan more patients who are suspected of GCA. But in general, if it's an unclear case, unclear pathology, unclear ultrasounds, and highly suspected of a GCA, they can come over for the PET scan. And particularly when the cranial is inconclusive, we cannot find it, we can confirm maybe on the large vessel activations. And so aorta is involved in the disease. So that's a good reason to perform a PET scan. You cannot find a cranial part. Maybe the PET can confirm in the aorta region and confirm the diagnosis of GCA. So that could be helpful. Follow-up, difficult to say. I think it's what we see in general is very unclear cases. It's unclear. Could it be disease, as described also by Christian? We are not sure. Is it activity again or ongoing activity? These kind of patients will also come up here for the PET scan. But we don't do a standard PET scan and follow-up.
Okay. Are there still questions?
There is one more question upcoming, and the question is: what is the rule for the extension of the arterial involvement seen, for instance, in the PET imaging technique? Is this of importance for the disease outcome?
Yeah, what PET can do, it can look at the extent, the total disease burden. Also, as I showed you, the total vascular score can also even quantify that in a score with a total disease burden. Yeah, most important is that you can find disease outside the cranial area. That's most important. The total disease burden, I don't know how important it is. It could be that this patient has a high burden, maybe responds well on treatment or does not respond so well on treatment. That could also be a very interesting research question. The extent of disease, how well does the patient then respond on treatment? That could be some more information on the PET scan.
Okay. Shall we move on?
Yeah, I think so.